You may gather from the accent that I'm not, I'm kind of from Australia, but not really from Australia. I'm an occupational therapist with the Victorian Respiratory Support Service in the aforementioned Australia, in Melbourne, and this is this talk is it's kind of the pointy end. We've done the physiological stuff and all that stuff. This is the get your sewing machine out, ladies. And I'd like to thank MNDA Victoria as well, as they helped finance my travelling here. So the VRSS is a statewide service in Victoria, and we cover the whole of Victoria. And to just give you an idea of what sort of area that is, it's about the same size as the Italian peninsula, but has the population of Sicily. So that's a little local information. We have approximately 800 people on non-invasive ventilation at any one time, and approximately 50 of those have motor neurone disease. So the role of our team is very much to provide the care and support for the people with motor neurone disease in Victoria, and we get between 90 and 100 referrals every year. This does lead on to in relation, a higher number of visits, a higher number of follow-up visits. So the occasions of service are more for the motor neurone disease clients because of the nature of the disease. So what we set out to do is to make the path as smooth as possible and to give out as much information as possible as early as possible. And we've accumulated knowledge by talking to people and both people with motor neurone disease and their carers to find out what actually they need and what's troubling them or what's likely to trouble them in the course of their disease. And we've come up with a number of solutions to different problems that people have come up with. But we also wondered, as part of this process, whether there were any things that we were missing from the information that we had gathered. So we decided to do a literature search and put in the usual vent-dependent patients, people with motor neurone disease sort of terms, and came up with a few, which I've also seen the references to on some of the other talks as well, which is rather reassuring. We also did a web search to see what other groups were doing similar things all over the world, and we contacted a number of groups in Canada, the 19 motor neurone disease centres for excellence in the UK, and also the Lane Fox unit at St Thomas's Hospital. We also know of a few other places in Australia who do similar things. We didn't dig down or couldn't find many places in America, and that's certainly something we need to do next. We also consulted with members of our team just to see what their thoughts were on this. So from Burke et al., the picture in the UK is that the numbers of being diagnosed are fairly steady, but the numbers who are being referred for NIV have increased. And as has been discussed, the bulbar onset is usually not a good place to be. We also discovered that there is evidence that the NIV improves the perception of the quality of life and also the duration of survival. So two good reasons to push NIV as being a useful treatment. And it was also discovered in one of the papers, which was most interesting to us, that early discussion of potential problems and potential solutions actually promotes compliance with NIV. So that was that slide, sorry. So as a team, we tend to get in there and discuss these things. So the fears and anxieties that people have, the discussion of the potential problems that people may have later on, and also offering people reassurance that we do have solutions to some of these things. And from our point of view, the solutions are very much fall into four categories. So there's mask management, communication, the pressure injuries, so nasal and also back of head, and also the element of community independence. So with mask management, this is the solution bit of, I suppose, of the discussion. I do have some examples of mask adaptations that we've done, and if you'd like to find me later and give me your email address, we can actually send through instructions of how to adapt some of the headgears and things. So our most popular one, this is the back of Amanda McLaughlin's head. She is my lovely colleague who put lots of this together. So I'm very, very grateful to her. So this is, as I say, one of our most popular adaptations. It does require some strength in elbow because you do have to pull the Velcro apart. So it's the mask is cut at the back and a piece of Velcro is set into it, and then you can pull that apart, and it just takes the mask away. So you can push it out the way or just get rid of it if you want to cough or shout or whatever. The next adaptation, which is very popular, and this can be useful in putting the mask on as well, is to have some extra loops around by the cheeks. This is one of the outreach nurses, and he's demonstrating that sometimes it's that something as simple as having a table that somebody can prop their elbows onto just to hold them up and they can then put their mask on, take their mask on and off. And this, used in conjunction with the short loop mask adaptation of the last slide, can be very helpful in both getting a mask on and off without having to fiddle with the fiddly clips. As has been pointed out, communication has a huge impact on how somebody is coping with the disease and how they feel about how it's going. So just being able to summon somebody else is very useful. And we use this particular setup, we lend these out, as do MNDA Victoria, and it's just an adapted remote doorbell. So the patient has the doorbell bit with the jelly bean switch into it. That's positioned so that they can nudge it with foot or cheek or hand or whatever, and then the sender unit or the receiver unit is then with their carer. And in hospital, we're able to provide a variety of switches for people, and that can be linked into our nurse call system. So that's useful. They can kind of get used to that, and then to have one of their own when they go home. Our colleagues, because we're a statewide and funded service, we are very lucky in that we have a good range of masks, and we can always be taking on new ones and looking at new ones to see how they work. So we have a nice range of masks, and as was brought up in the last discussion, in the last presentation, just being able to use the different interfaces. So perhaps the wisp or the little swift that goes, just sits under your nose is a very useful way of reducing the pressure across the top of the nose. So they can be used during the day, and then a full face or a whole face during the night. And we recognise how lucky we are to be able to do that. I did it again, didn't I? There we go. So very often we find bridge of nose around face and sometimes back of head as well. So some people get them down the sides of their nose. So in order to alleviate some of these things, we have a number of dressings which we've discovered or have investigated and found that these are the most useful. Very often the dermal pad is useful in the grade 1 dressing, although it can be a little bit bulky sometimes. It's like a silicone stretchy stuff. The Mepilex light is rapidly actually becoming our favourite. It's a slightly foamy and has a low tack. So when you stick it on and take it off again in the morning, it's not going to erode all the cells which have been happily growing. Excuse me. And for more eroded noses, we tend to use AquaClear, which is again cut into a sort of boomerang shape and then put over the nose, and then usually with AquaClear it's just taped down and then some other interface is used. With the back of the head, sometimes when people are quite immobile, that can be a bit of a problem. And we've got two solutions to that one. One is just to put a piece of sheepskin across the back of the mask, which just spreads the pressure around a bit. It's a bit, ramshackle and odd looking, but there we go. It seems to work. And the other one we use if they are, if the patient is very much in bed, then we take a pillow, take 2/3 of the stuffing out, and put a bag, not a plastic bag, a bag of made of 2-way, 4-way stretch material, 3-way stretch material even, into the middle with cut-up pieces of memory foam in, and that just forms a nice soft barrier for them. And then if there are any difficulties with the wrinkling of the pillow and things like that, we also put a satin cover over the top to reduce the friction. So community independence is also an area that we do look at. And the provision of vent trays is very useful. We encourage everyone to have separate batteries for their ventilator and their wheelchair, because if you need the ventilator, you need the ventilator, and you want to be able to still move around. And we have a very a good relationship with a local not-for-profits organisation, so a local charity, somewhat like REMAP in the UK. They've changed their name to Solve Disability Solutions, and they provide, they make and modify people's equipment so they can make the vent trays, and the client only pays the cost of the materials, which is very reasonable. Because some of the ones that we've had manufactured by the wheelchair manufacturers are hugely over-engineered, massively heavy. You could drive a tank over them and they wouldn't do anything, they wouldn't bend, but a bit too much really. We also have begun using mouthpiece ventilation, so people could use the mouthpiece ventilation during the day and then be using the full face mask overnight. And it just means that there's less of a barrier between the person and their carers, the person and eating and just getting on with their lives. And people do find that it does enable speech and eating and all those useful things. We do have some difficulties in actually setting it up. This is a setup that we think is probably close to very good, but it doesn't always work. So a lot of it depends on things like the duration of use. The easiest way for people to use it is actually to hold it themselves, but obviously that's very fatiguing if they're needing it for longer times, longer periods. We also have to rely on the carers who have to assist in actually setting it up, and that can be troublesome as well on occasions. And also some people tend to move around a lot in their wheelchair, so they recline, they tilt, they just sort of wiggle around a great deal. And also some people, obviously when they become more fatigued, they may find that they subside to one side or other. And that can move you away from the good position of the mouthpiece. So the bits that we found that actually support the mouthpiece that we have are a very simple audio-visual cameras and audio setup. So you have a nice clamp that will go around square bits of wheelchair or round bits of wheelchair or whatever you've got. Then a gooseneck, and then a little adapter and a microphone clamp to hold the actual tubing. We use short lengths of tubing as well to avoid the dead spaces within that, and also the ventilator that we use has been adapted so that some of the alarms aren't quite as eager, because otherwise they'd be alarming all the time. So that's very useful, and that's done in conjunction with our physiotherapists and nurses, outreach nurses. So the clinical outcomes of this have been that we have a range of adapted mask straps. So it's mostly the physios and OT and nurses who give those out, but we're able to come in and assist them if there are any others any extraordinary ones that they need. Overall, our hope is that as a team we can facilitate the reduction of anxiety, an increased sense of independence with mask management and the management of the machines. Also the communications both on the ward and afterwards, and the pressure injury information, so that if that occurs, people know what to do. So we're looking to promote the mask independence. We're also looking at functional goals. Primarily, it's looking at preempting change. So we warn people that these things may happen so that we can actually say, we have got a solution to this. It isn't the end of you using NIV. and also some hints on preventing pressure ulcers. We don't have fancy equipment. That's our sewing machine, our very sewing machine, and also imagination. Here are the references. And thank you very much indeed for listening. I'd like to say a very special thanks to MNDA Victoria for funding my trip, also to my colleague Amanda, and thank you very much for listening. Any questions?
Any questions? No questions? Yep.
How do you get on with your wheelchairs?
In what way?
Well, certainly in the UK, I think that's one of the biggest problems that we're grappling with at last, and the Department of Health is helping.
Mm-hmm.
So it sounds that your unit is really doing really well. So I'm just thinking, how do you deal with the wheelchair business, which is one of the...
I'd like to hand over to my lovely colleague from MNDA Victoria, who have a lovely stock of them.
We actually run an equipment library, and all of our electric wheelchairs are fitted with ventilator carriers before they're delivered, whether someone needs them or not. But they can be fitted retrospectively. We've worked closely with VRSS to make sure that we're able to reflect changes in technology, and we don't seem to have any problems. We can get electric wheelchairs to people fairly quickly. We run a stock of about 100 of them, and away we go. We use, that's a very good point. We use a third-party supplier who manages all of our disability aids and equipment. We do a full range from a urinal through to an electric wheelchair, but we don't do communication devices. Our third-party supplier stores, delivers, provides some introductory training on how to charge batteries, for example, provides ongoing maintenance, regular servicing, recovers when it's no longer needed. It's then triaged, repaired, scrapped, or cleaned and reissued. And away it goes again. I must be one of the few CEOs in the world that controls about $2.5 million worth of assets that I've never seen.
I've seen lots of them. They're there, honestly.
Any other questions? Sarah?
Hi, I really enjoyed that. I love the adaptations to the mask, and I want to take that back to our OT. Do you have other things, like for people who can't get their collars on and off, or doing a peg tube, that you'd also be willing to share?
We haven't focused on any of those yet, but we're always willing to look at a challenge and do a bit of problem solving. So these are the main ones that we find on a regular kind of day-to-day basis. We have for people with diaphragmatic pacing, we have made special belts and special pouches and all kinds of things so that all the wires are kept in the right place if they still have a certain amount of movement. So we do lots of odd things. Frankly, but if anybody wants to see any of the mask adaptations and things, then do come and find me, and I can show you how to do it and send you the recipes.
Can I just say that having chaired this meeting for a few years, it never ceases to amaze me the flexibility and creativity of you at making things work for people. And I think that's one of the great things that we have in our industry, is we have people who use what's between there and these to come up with solutions to everyday problems that every patient experiences. Yeah. One last question.
Thanks for a great presentation. You showed some wheelchairs there, some electrically powered wheelchairs. Now, one of the problems some of our patients and carers have been reporting is when they want to propel, or when they want, the ones that are not electrically powered, but need a place for the ventilator to go on, when they want to push that wheelchair, they find it very difficult because A, it's bulky, B, it pushes the propeller away from the wheelchair. How do you get around that problem, please?
In a way, it's not a problem we face very often. If somebody is at the stage where they do need ventilation, then very often because we have such a ready supply of electric wheelchairs, thank you, we do find that's that they'll get the electric wheelchair very soon, or they've got it already, but it is difficult. We do have patients with other conditions who have a similar problem, that it's really difficult to propel your wheelchair when there's a huge great thing hanging off the back.
Because it pushes the carrier away from the wheelchair. Basically,
yes.
Biomechanically, it's not good.
No.
So do you have other ways of adapting that? Like, can the tray go under the wheelchair seat, or?
I think at the moment, what Melanie's saying is that if someone's using a ventilator, they're using an electric wheelchair, and we'll give them that in advance of a manual wheelchair. Manual wheelchair design's pretty traditional, and it's really hasn't been set up for the unique needs, I think, of a vent carrier. Once you put a vent carrier on a manual chair, very difficult to fold, and that means very difficult to transport. So we tend to move people straight into an electric wheelchair. So it conserves their energy. They can stack the vent on if required.
Okay, thank
And
you.
also the ventilators are getting smaller and smaller, so there's more capacity for not having such huge. Even when I started not long ago, there were great big blocks of ventilator.
Okay, please join with me in thanking Melanie.